Bismillahirrahmanirrahim. Respected judges and distinguished guests, my all teachers, Assalamu alaikum. And first I want to thank you IPDI for giving me this opportunity. This is my very first presentation, so I try my best. I am Dr. Fauzia Khan from Bangladesh Specialized Hospital, and today I will present the case regarding ST elevation MI rather than non-STEMI. My patient, 53 years old male, he was diabetic, hypertensive and dyslipidemic. Patient came with chest pain for 11 hours and it was central and retrosternal. And regarding his previous history, patient was on irregular medication for hypertension. And 2 months before, he has done his echo, which shows only there was no regional valve motion abnormality, only there was concentric LVH with good LV systolic function. And on examination of the patient, he was hemodynamically stable, only there was rise of temperature. It was recorded 100° Fahrenheit. As a patient has taken the COVID booster dose 1 day before coming to this hospital. And before coming to our hospital, patient went to a local doctor where ECG was done and his troponin was raised. So he has got his loading dose from outside the hospital and came to our hospital for better management. Okay, up to this history, what you will think, it will, maybe the ECG was not, there was nothing significant and ischemic. So I will show the ECG later. Up to this history, what you will think, it's acute coronary syndrome and probably it's non-STEMI as the troponin was raised. Okay, let's see what comes next. Okay, this is the first ECG was done outside the hospital, and what you will see, there's nothing significant, apparently normal ECG. The second ECG was done at our emergency ward. It was again a normal sinus rhythm, nothing significant regarding ischemia. The third ECG was done at our CCU when the patient shift was CCU, and here you can notice there is a premature contraction, and again, there is nothing to be significant. Okay, but if you please correlate these three ECG, only one thing you can appreciate, that there is a height of R wave a little bit more in V2. And the patient in front of you with clinical typical symptoms of ischemia. What you will do next? Okay, then we go for the posterior lead ECG. And you know what we'll find in that posterior leads? There is ST elevation in posterior leads ECG. That means actually the patient, I will say patient, not we doctors, are actually dealing with true acute ST elevation MI posterior. His lab reports were almost normal, only troponin was raised. First sample was done outside the hospital and second was done at our hospital. It was significantly raised. And his TG level was raised to 79 milligram per day, and others were almost normal. His echo shows no regional valve motion abnormality, good LV systolic function. There was only concentric LVH. As it's in COVID situation and it was almost 3 a.m. at night, so we thought for pharmacoinvasive procedure. That's why we thrombolized the patient with tenecteplase, and we planned for coronary angiogram on the very next day. And this is his coronary angiogram shows there is 99% stenosis at his mid circumflex, and on the same setting patient was revascularized with TIMI 3 flow, and patient was good and hemodynamically stable during and after the procedure, and patient was discharged 2 days after the procedures as routine. Okay, now posterior MI, what we'll find in posterior MI, there will be ST segment depression. Though it's ST elevation MI, but it's will not find any ST elevation in our regular ECG. There will be always ST depression. Where the depression will you will find this depression in the septal or antros precordial leads. That means lead V1 to V4, and this occurs because think one thing, that the precordial leads are attached on the antero surface of the chest, but you are dealing with posterior wall MI and it's on the posterior surface of the heart. Okay, that's why there will be no elevation, there will be mirror image. That means there will be depression. And you can find this R height of R and S ratio more than 1 in lead V1 to V1 or V2. And you will find ST elevation, but on posterior leads. If you do posterior leads, then you will find the ST elevation. And there will be suspicion of a posterior MI must remain high, especially if inferior ST elevation MI is also present. And what the guideline says, the ESC guideline, 2020 ESC guideline said that regarding the management of acute coronary syndrome patient presenting without ST elevation, ST segment elevation, there will be class 1 indication to do right side or posterior ECG. And this is the lead replacement. You will replace the lead on the back side of the chest. It's very simple. Left V7 will be placed on the left posterior axial line, V8 will be tip of the scapula, and V9 on the left parasternal line. As the V6, horizontal plane as V6. And on regular ECG, there will be ST depression at least half small square. That means at least equal or more than 0.5 millimeter. And there will be a tall R and upright T waves. On posterior ECG, there will be ST elevation more than half small square. That means it's a mirror image. That means in ST elevation, you will find ST elevated. In posterior MI, there will be ST, horizontal ST depression. In place of Q waves, there will be R wave, and in T inversion, there will be upright T waves. Posterior MI, is that posterior MI is common? Yes, posterior MI occurs mostly associated with the inferior lateral wall MI, and it accounts about 15 to 20%, but isolated MI, it's only 3 to 11%. And why it's important? Because it's, you are dealt with non-STEMI for early invasive, but rather than ST elevation for primary PCI. So the take-home message is, true posterior MI is commonly missed by the general practitioners, and mostly by the, it's also maybe missed by the cardiologist. And ECG is a simple, very simple, easy, cheap, and easily available diagnostic tool. And patients having symptoms, you must look for acute MI. And all patients should come with you with chest incontinence. Please do an ECG, and you should do the posterior lead ECG. Is the ECG is inconclusive? And posterior MI is must, because on ECG it's non-STMI, but actually it's a ST elevation MI, and we should not miss it, as we can schedule the patient for primary PCI. And thank you very much for patient sharing.